Okay, so we're right at the hour, so we will go ahead and get started. Give folks a few more minutes to join. But hello, everyone. Welcome to today's FSHD University. We're very excited to have you. My name is Ashley Ferreira, the Director of Education here at the FSHD Society. And on behalf of the Society, thank you for joining us for today's FSHDU on the economic burden of illness of FSHD. A quick reminder before we get started. If you do have any questions during the presentation, please ensure that you use the Q&A function at the bottom of your screen. That helps us with organizing the questions so that we can ask them during our Q&A portion. This session will also be recorded and made available within a week or so on our FSHD YouTube channel, so make sure that you check it out on there. And please feel free to use the chat. We encourage you to add any comments there, introduce yourself, let us know where you're from. But again, if you do have any questions, please make sure that you use the Q&A function. We are going to go ahead and get started, and I am actually pleased to share that today we are joined by Amanda Hill, our Research and Care Program Officer here at the FSHD Society. Amanda Hill oversees some of our key research initiatives, such as the Better Life program and other programs that help advance clinical trial readiness and data-driven discovery here at the Society. And so we're very excited through her background in research and extensive experience in managing complex different projects. She plays an essential role in driving the Society's mission to accelerate treatments and improve care for individuals living with FSHD. And so we're very excited for her to share some of the findings from the Burden of Illness Survey. Her co-presenter, unfortunately, Kinoshita, our former director of patient or research education, will not be here today. Unfortunately, she had a flight delay, but we will make sure to present what we can on her behalf, and so we appreciate it. So with that, I will pass it over to Amanda to get us started.
Excellent. Thank you, Ashley. Everyone should be seeing my screen now. I'm going to assume that's the case unless I hear otherwise. But I did want to just tack on and say a big thank you to June. She did play a pivotal role in initiating this work at the Society several years ago. I'm very honored to have worked beside her on these projects and to continue to carry the torch forward. I'm disappointed she couldn't be with us here today to present, but I assure you, you are in good hands with me. So with that, I'll go ahead and kick us off. So in order to start to get at this topic of what the economic burden of FSHD is, we have been working in an area of research called cost of illness. This is also sometimes referred to as burden of illness. You'll hear them used somewhat interchangeably. So cost of illness, what is this? These are a type of study or I should say, cost of illness is an approach that studies all of the costs linked to living with a disease, such as FSHD. And that includes costs to patients, also their families, and also greater society. So a common framework that's used in cost of illness to categorize the types of costs included is what's bolded here on the bottom is to look at medical costs, non-medical costs, and indirect costs of the disease. So I want to take us through a little bit more of what that actually means. This is a framework that we used in our studies and why it's important. Okay, so when we think about the cost of FSHD, there are some costs that are quite obvious, and I would liken those to seeing an iceberg above the surface of the water. You can see them there, they're hanging out, they're quite obvious. These are often medical costs, doctor's visits, lab tests, medications, medical equipment, surgery that you might need associated with FSHD. But there's actually a lot more cost associated with the disease that can often be below the surface, not as visible, not as obvious, harder to research and understand. And actually, it can be really huge and impactful, and maybe even be bigger than those visible costs themselves. Hence the analogy to an iceberg. So the other types of costs that we look at here are non-medical costs. These are things that are not medical, but still related to the disease. For example, people have to make modifications to their homes or vehicles in order to continue being able to perform just daily activities. Folks might need help with personal care or activities around their house because they're not able to do some of the things that they used to be able to do. So we look at all of these sorts of costs and we include these in cost of illness studies. The third type of cost is indirect. So these aren't necessarily things that are come out as an expense on your bank account, but they still have larger impacts to society. This can include missed work. This can be income that was lost or forgone because you had to retire early or miss lots of days of work because of a procedure. It could be opportunities that you lost because of your FSHD and overall lost productivity to the workplace and in the economy. So, as important and impactful as all of this information is, globally, we actually know very little about the cost of illness or the economic burden of FSHD. There have been just two studies published in the literature on the cost of illness. One was in the Netherlands and one was in Germany. But outside of that, there hasn't been very much. So this is part of the reason why we started down this road. So why does this matter? Why do we need to study this? First of all, understanding the cost of illness helps us be able to raise awareness about the real world impact of FSHD. It also allows us to help inform decision making of payers. Now, I want to talk just a second about what a payer is, because this might be a new term for some folks. So payers in the US are your insurance companies, Medicare, Medicaid. They're the ones that pay for a lot of medical procedures and costs. In other countries, payers are often akin to a national healthcare system, or it might be a private insurance company or some combination of these. It can vary from country to country. But payers have to make decisions about what sorts of services or treatments they will cover, who's eligible for that coverage, and what the pricing is going to be for those. And so this type of data about cost of illness is it's an important input into that decision-making process for payers globally. We can also use this information to advocate for funding and support. That could be from governments and policymakers, for example, to invest more in research, to invest in better treatment options, or to provide more access to or support for services that are needed from the community. And finally, we can use this information to show the impact that FSHD is truly having on families. And we can highlight areas of need that are often overlooked. For example, the impact, social and economic, to a caregiver or other members in the household. It goes beyond just a patient. And these areas are not often well understood or researched. So we can use this information to highlight that and again, raise awareness and argue for more research in these areas. So I am going to share with you all the studies that we did in this area. There were two, and what our results were. Before I do, I just want to quickly caution that there are people that spend their entire careers working in this area of research. I am not one of those people. I am not an expert in cost of illness. However, I know a lot about FSHD. I know a lot about research, and we partnered with experts in this area to do this work. So together, our study team, I think we did a really good job of pulling together the information that we had, and I am representing our whole study team to share with you what we did to collect, analyze, and make sense of this data. And I will answer as many questions as I can, and if not, I will take those questions back to our study team. Okay, let's get into it. So I want to start by sharing with you our study design. So how did we approach this question? So our goal was to estimate those three categories of costs: medical, non-medical, and indirect costs of FSHD in the United States. Now, this approach was for us where we started, and I will say that while these results are specific to the US, they will help to inform further study in additional countries and will provide a helpful starting point for ongoing work globally. So we used two approaches to our study. The first was that we used insurance claims data to understand what sort of medical costs were paid by insurance. Um, this data came from a large national database of insurance claims information, both from Medicare insurance coverage as well as your regular commercial insurance, for example, United Healthcare, Blue Cross Blue Shield, etc. The information in these databases are de-identified. That means there's no personal information that would allow us to see who these people are that had these costs or had these claims. But we can still find people with FSHD in these databases using the ICD-10 code for FSHD. And when we use that code, we can then say, okay, what insurance claims were made for care, for services, medical equipment, prescriptions for anyone who had FSHD. And I'm going to take a little side note here and just make a plug for this is one of the reasons why it's so important that everyone make sure they have the ICD-10 code for FSHD on your medical record. Um, and I'm going to ask Ashley, we've got a page on our website that talks about the importance of this. It gives you the code. And if she can add that link to the chat right now, that would be lovely. But having that code on your record allows this type of research to be done. And then the other approach, the second approach that we used was a patient survey. So in this survey, we asked families what sort of medical costs they paid for above and beyond insurance. We asked them about the non-medical costs that they paid for. And we also asked questions to help us understand what the larger indirect costs might have been of the disease. This survey was called the TrueCost of FSHD survey. Many of you listening may have actually participated in this. I want to say thank you so much for doing that. We did this survey a couple years ago now. It was a big survey. It was a lot of time for the folks that participated. We had over 300 people respond to that survey. Many of those folks had multiple family members with FSHD, so they were providing information for all of their family members in their household. Um, and it was a very, very important information that we were able to gather here. Okay, so I'm going to go through the results of both of these approaches kind of together. I'm going to merge them a little bit together. We're going to walk through the medical costs that we found, the non-medical costs, and then the indirect costs. Oh, there is the ICD-10 code G71.02. That's it. All right. So starting with the medical costs that were paid by insurance. This came from the insurance claims database. This bucket of information includes costs from any procedures that were done, services that you had. So if you needed blood work, a certain test, just to see a specialist, doctor, all of those things are included in here. Durable medical equipment, anything that was covered by insurance, as well as prescriptions. And we looked at both commercial insurance and Medicare insurance. And we're looking at all of our costs here as an average annual cost per patient. So things can fluctuate year to year, but we're averaging them out over the course of 12 months. And we're looking at everything per patient. So for people that had a commercial insurance plan in our cohort, the average cost per patient of these procedures, services, medical equipment, and prescriptions was almost $12,000 per year, paid for by the insurance companies. But for those that had Medicare, it was a little lower, a little over $9,000 per year. In this particular part of our study, we also were able to look at a control population. So we compared the FSHD population to just the general population. And the costs in the FSHD group for those with commercial insurance were over 3 times higher than the general population, just to give you a sense of how that landed. Okay, next, we're going to go into the survey information. So the rest of this is now information that we heard from families that they are paying for and they are being impacted by. So I'm going to walk you through, there's a lot of information on this slide. I'm going to show you how it's set up because the next couple slides are set up the same way. So We're looking at medical costs still here. We asked about several different types of costs. So we've asked about health insurance premiums, durable medical equipment, routine medical services. So your regular going to a doctor annually, any sort of typical things um, that you would do for medical care. And then contrasted to non-routine medical services. So if you had an emergency room visit or needed some sort of a special procedure, that would be in here. And then skilled nursing care. So this is like an in-home, more full-time nursing care that some folks require. And then what I'm showing here, percent with cost, not everyone in the survey had all of these costs. So this is telling you how many people in the survey, what percent of them had this type of cost. So most people, 86%, were paying out of pocket to some extent for health insurance premiums. Similarly, most people in our study, about 85%, had paid out of pocket for some sort of medical equipment. But by contrast, very few people needed skilled nursing care. And then the other thing here on the right that we're showing is for the people that had this cost, what was their average annual expense? So for that 86% of people who were paying for premiums, on average, that expense was about $7,600 per year. So as we look down this, you can start to read through and see how these expenses, what types of these expenses came through for families and how big that they were. I do want to note here, so some of these things are paid for on an annual basis, such as health insurance premiums. We're all paying for that every year. But some things you don't pay for every year. A good example might be medical equipment. You might spend a lot of money on a wheelchair, but then you don't have that expense again for many years. So in our survey, we thought forward about this and we asked people to reflect back on, since they were diagnosed, what sorts of costs they may have incurred to the best of their memory and their records for these expenses. And then we averaged them out over the course of how long that person had been diagnosed in order to get this average annual cost. So in your experience, for example, you might have had to pay a lot more than $1,500 in a year for durable medical equipment, but if you average that out over the 5 or 10 years that equipment lasts, that's how we came up with that number. So this is true in general across all of the results that I'm going to be explaining. So running down the rest of this slide, we've talked about health insurance premiums, durable medical equipment, routine medical services. About 80% of people were paying out of pocket for these, about $2,800 per year on average. Non-routine medical services, this looks quite low, but I will say, having seen the data, again, this is something that doesn't happen every year. Hopefully you don't have an emergency room stay every year, but when you do, it could be quite expensive. So again, that gets averaged out over the course of the lifetime. And then finally, skilled nursing care. This is actually a very expensive one. If you look at the x-axis here of this graph, we go from showing, $2, $4, $6, $8,000. There's a gap here all the way up to $120,000. This is a very expensive service to receive and to get. And we actually we calculated the cost of skilled nursing care based on Bureau of Labor Statistics wage data for the folks that would have received this. So some people might have some insurance coverage for this, some might not. We didn't have that information, so we made one large calculation based on standardized data to estimate what this cost would be. Okay, there's a lot that I'm going to throw at you here. So please ask questions in the panel that Ashley pointed out as they come up, and we'll happily come back to these slides and answer those questions. Okay, next we're going to move on to non-medical costs. This is where we're getting to that below the surface part of the iceberg, where things are often not as visible. So in this part of the survey, we asked people about 5 different types of costs. The first we asked about were housing modifications. So if you had to do remodels to your home, even purchase a new home, small or big, whatever those costs might have been, we asked folks to tell us how much, over the course of their life they had paid for these things because of their disability, because of their FSHD. In our survey, a little over 75% of people had to make some sort of modification to their home, large or small. And again, when we average that out on a yearly basis, it was almost $10,000 per year for the folks that had that expense, which is quite huge. Similarly, we asked about transportation. So super common here were vehicle modifications. Some folks also needed to just pay for special types of transportation to get to and from appointments. So we captured all of those costs. A little over 50% of people had these costs, and they averaged out to be a yearly cost of about $2,700. The next thing we asked about was when folks needed help with just common activities around their house because they could no longer do things like mowing the lawn or shoveling snow or making a small handyman fix to things in your home. Normally you would have done that, but now you can't because of your FSHD. So how often did you need help with those sorts of activities? And this sometimes might mean that another member of your household is now taking on that duty, but it might also mean that you're paying someone to do that instead. So we asked about the number of hours total that you needed help with those things. And then again, we used standard wage data to calculate the value of those hours, whether or not you paid for it or it was actually just given by someone else in your household. The value of that time came out to about $10,000 per year on average. The next thing we asked about similarly was help with personal care activities. So if you need help dressing yourself, going to the bathroom, getting in and out of bed in the morning, again, you need someone there to do that. So either that's a household member, a caregiver, or you might be paying someone to come in and provide that support to you. So that the value of that we calculated to be almost $12,000 per year. And about 37% of people in our survey needed that support. And then we have a little bit of a catch-all here for other types of costs in this non-medical bucket. This included a variety of different things. For example, people that needed special foods or diets, folks that had, we included wheelchair batteries here if you needed legal support, maybe for some accessibility or disability issues, other like specialized exercise equipment. It's kind of a catch-all for all other things that were added costs for you because of your FSHD. And that came out to be about $3,900 per year, and 88% of people had still something else in this other category. Okay, the last big scary slide before I provide a little more, some easier things to look at, is now the indirect cost category. So the indirect costs that we looked at were life insurance premiums. This is one that families will often pay for out of pocket, but it is categorized here. This is just a standard way that this is done in the field. So we had about 43% of people that were paying premiums for a life insurance policy, and those folks were paying on average about $3,400 per year. We also asked about long-term disability insurance premiums. About 25% of people were paying for that with an average cost of about $3,300 per year. And then we got into some more interesting categories that look at kind of larger impacts to society and productivity, and types of lost income that people just weren't ever able to get, that in theory they should have been able to have that income. So the first thing that we looked at here was lost income from what's called absenteeism. So this is when you miss a day or two at work because you had to go to a doctor's appointment, you were especially tired or not feeling well, or maybe someone in your household had to miss a day at work to provide you support for one of those things. So a pretty large number of folks in our study had lost income due to this, about 82%, but they weren't losing a ton of income on average. It wasn't a ton of days overall that they were missing. So that cost ended up being a little over $900 per year. Now, we also asked about lost income because you or someone in your household was just no longer able to work at all because of FSHD. So again, that might be a patient, someone living with FSHD. It might also be a caregiver or someone in the household that now needs to stay home full time for support. So about 31% of people had this type of lost income. And we didn't ask people, oh, what were you making before? And then calculated that out. We used an average personal income for the whole US based on census data to make this calculation. And so we estimate here that that cost came out to about $21,000 per year. And then we also had folks that they retired early. And so maybe 5 years early, maybe 10 years early, whatever that was, about 45% of the folks in our survey had this cost. And we calculate that to be a little over $33,000 per year. So what's the true cost of FSHD? If we add all of this up and we look on average per patient per year, we come up with an initial estimate $71,835. This is the three categories that we just walked through, showing the breakdown of how much each of these categories contribute to that total. So here in orange are those medical costs. It's exactly 1/3 of the total. That's that top of the iceberg that's usually a little more obvious and visible. But then under the surface, the other 2/3 of that cost were made up of non-medical costs here in yellow, about 32%, and then indirect costs here in this teal, 35%. The thing I want to say about this is that you're sitting out there living with FSHD or a family member is, and the financial and social and economic strain of FSHD feels heavy to you, you are not alone. This is very real. And for the first time, we've been able to put an actual number to it. And I will caution, if this wasn't already clear, all of these dollars are in US dollars for the US costs that we've calculated. All right, get my slides back. Good. So a couple of things I do just want to say about these results and some cautions about how we interpret and understand what we've found so far. So we had, as with any study, there are limitations to what we've done, right? So I want to highlight a few of those things here and urge caution as we interpret these results. The first of which is that we actually didn't have complete information on those insurance costs. So because of the way we did the study, we didn't have full view into that data. So we know that we're missing some key information and we had to just make some assumptions and make some inferences about it. In our TrueCost of FSHD survey that we did with the patient community, we know that the people who responded to that survey tended to be older and tended actually to be in a wealthier income bracket. So it's hard to say exactly what that means for our survey results without doing more studies. I could think about ways that it might mean that our survey results came back with higher costs than might actually be, but I could also think of reasons why it could be lower. It's really hard to know exactly what that means until eventually we do more studies and make sure that we've caught the full representation of people with FSHD. Because of the design of our study and some of the information we didn't have, it's possible that we double counted some costs related to supportive care, specifically that skilled nursing care, because sometimes insurance has some coverage for this, but sometimes not. And that's a piece of information that we didn't have. And then finally, I want to say that we do, even in spite of all of this, we suspect that these initial estimates are actually conservative, and that as more studies are added on and we have a better understanding of this, that number is actually going to tick up a little further. And if you haven't heard me say it enough, more studies are still needed. Okay, so this is my last slide. Why is this important? How is this now going to be used? What happens next? So this is the very first study to estimate the cost of illness in FSHD in the United States. That alone is huge. This is a very important piece of information to have moving forward. So we are in the process now of publishing our findings in open access journals. That means anyone can access that article. It's not behind a paywall. So we actually have two different manuscripts or papers that are coming out of these studies. The first one has already gone through a peer review process one time. It's going through the second submission of peer review right now. We hope that that will be published and available very soon. The second manuscript that we are writing, all of the data analysis is done, as you have seen, and we're working on drafting that paper now. Um, as we move forward into 2026, 2027, as we get closer and closer to having treatments, our first treatments available for FSHD, you can bet we will be using this information to be generating awareness of the unmet needs in the community. No one's seen these numbers before now, and I think this provides very strong foundation for us to be advocating for the needs of the FSHD community. So some ways that we're going to be doing that, this will be used to provide education on the economic burden of FSHD, especially to payers and insurance companies and healthcare systems. They probably don't realize all the costs that they are expending on FSHD. This will also be important for pharmaceutical companies that are developing drugs to understand. We will use this to advocate for coverage of treatments when they become available with insurance companies, with healthcare systems, and also to further advocate for continued funding and support. So that is all I've got. That is what the information we have right now on the economic burden of FSHD. And I'm very happy to take any questions that might have come up.
Excellent. Thank you so much, Amanda. And we did have a few questions, so we'll go ahead and get started. Have you sorted this data by age or stage in the progression of the disease?
It's a great question. Um, we have done an initial look, sorting it by ambulatory status, kind of. So let me explain why we did that. So I didn't show the information here, but in that patient survey, we did do a breakdown of those three categories of costs by whether or not someone was completely ambulatory or was using some sort of an assistive device, part-time, using some sort of an assistive device, or maybe a part-time wheelchair user versus someone who was a full-time wheelchair or scooter user. So that we did that to get an initial estimate. We use that ambulatory status as kind of a marker of disease progression. I know that's not perfect, and that upper body plays a really important impact. It's harder to measure that though as easily in the data. So we use that ambulatory status as an estimation. And we did see, not unexpectedly, that costs in all three of those categories, they tick up with each of those moves, moving from one category into the next of that assistive device use. We haven't done that with the insurance data because we didn't have enough information to be able to do that.
Thank you. Do you have any info about how this burden compares to people living with other conditions?
A little bit. I couldn't give you the comparison right now off the top of my head, but there have been some really great studies done in other muscular dystrophies. DMD in particular has had a lot of work done in this area. And there's also been some studies done on larger rare disease burden in the US and globally. So I couldn't tell you though, I couldn't tell you the exact comparison to other diseases. One thing I will say is that for diseases that have treatments on the market already, FSHD looks cheap because those treatments are very expensive. We don't have that yet. So there's not, it's hard to always make that comparison.
Thinking about the comparison, so do you compare the cost of FSHD with the income of FSHD people?
We have not done that yet, but that would be very interesting because, as I mentioned, our survey cohort did skew towards a higher income level. So it would be very interesting to look and see, did those people with the higher incomes have more expenses because they had the ability to pay for them or not? Maybe it doesn't correlate. I don't know. We haven't done that yet.
Thank you. How does the result, approximately 71,000, compare to the other two studies in Europe? And can you actually explain what those other two studies are?
Yeah. So what I'm going to speak to the Netherlands study because I remember that the best right now. That one was limited to the direct medical costs, I'm almost certain. And if we look at just the direct medical costs in our insurance claims versus what they did in theirs, which is kind of the similar approach, they're very actually quite similar, which is interesting because our healthcare systems are different. So it's hard to make that direct comparison because healthcare systems, depending on how they're structured, they're going to have different costs. But the Netherlands study and our insurance study came out quite similar. Um, I can't I can't make other comparisons at this point, but I could look that up.
Thank you. Um, could insurance companies use this data to deny coverage or services to people with FSHD?
To deny it,
Yes.
hopefully not. We're aiming to use it for the opposite, to advocate for why they need to cover this because of the expenses that are being incurred without it.
Can you just expand a little bit more about how the cost of illness helps influence healthcare policy, insurance coverage, and funding for future therapies?
Oh man. Yes. So having this data gives a foundation for example, healthcare systems to understand this is what I'm paying for FSHD, and this is what society and families are paying for FSHD without a treatment. And if we can have a treatment, for example, and prevent a lot of these costs, we can make estimations on this like economic model for how that will affect all of these different layers. And so it's one of the many inputs that goes into this decision making. But having this data gives them that cost information so they can plug that into there's a lot of economic modeling that goes on. So they can plug into that economic model and understand how FSHD impacts, for example, their healthcare system. When it comes to policymakers, um, I think it's really an awareness of what the real impact is. It's easy to hear an obscure disease and think, oh, it's not impacting that many people. But when you can put some numbers and put some meat behind that, it just adds urgency and it adds a better understanding that can alone, I think, play a really big role in policy and policy making.
How do insurance coverage gaps or limits on therapy visits increase the financial strain for FSHD patients? Is that something you were able to see through the study?
Insurance coverage gaps or what? Can you read it again to me? Oh, Ashley, you went muted.
Sorry about that. How do insurance coverage gaps or limits on therapy visits increase the financial strain for FSHD patients?
Yeah. That wasn't something we were able to look at in our studies, but we can project and estimate that that would obviously increase the direct cost to families when insurance is not covering it.
I think you touched on this a little bit, but does that we didn't get much information on this, but does having Medicare or private insurance significantly change out-of-pocket costs for someone in FSHD?
Oh, we could look at that information, but we didn't do that. That's a really great question. I don't know.
More work. That's great.
Yep, yep.
Perfect. Do you have any ability to sort medical costs according to those incurred for health maintenance or prevention? E.g., I have paid more for, or I have paid for chiropractic care for years as a health maintenance activity.
Health maintenance or prevention. Yeah, I mean, I think most all of the costs that we're seeing now are for maintenance or prevention. None of them are really for treatment in the sense that there are no treatments available. Um, so we do have our survey did include like a pretty specific breakdown of the types of providers people might be seeing, for example, chiropractor, acupuncture. So we could certainly make some of those inferences, I think, about how people are using those services. Um, but I'm not sure we could do the exact breakdown that you're asking about.
So this is a bit of a long one, but it's kind of scenario based. So as you were speaking, another type of cost came to mind. As those of us with FSHD pay out for extra health related expenses, our savings are reduced or the ability to create savings. This in turn impacts the amount of our estate or the amount of money we can pass on to our family, etc. Some
Mhm.
of those family members in the younger generations may also have an FSHD diagnosis and face these extra costs that you've shared. Has this impact been included in the study? Is there a way to have measured that? Was it basically considered as part of the financial cost
Well,
study?
that's super interesting because when you start thinking about long-term savings, you're talking about compounded interest and growth
Mhm.
that you're missing out on, and it just gets bigger and bigger over generations as you're thinking. So, no, that is not something that we asked after. I would assume that there's probably a methodology out there to do that, but I don't know off the top of my head. So that's something else I could take back to our team.
Thank you, Amanda. Um, how does understanding the cost of illness help researchers design more effective or realistic clinical trials for FSHD?
Hmm. You know, it's maybe where my head is going is maybe a little less about designing trials, but a little bit more, a little after that point when we get to when we get to the point of making decisions about therapies. So we could draw lines back to a therapy had this effect in a clinical trial. So maybe it reduced, or I should say, maybe it improved. I'm going to make something up, a 6-minute walk test by 20% or something like that. But if we can get to the point where we can actually make extrapolations from when we know someone has this much improvement in their walking ability, we think that that could account for a certain amount of cost. That's part of the economic modeling that I was referring to that ideally we would be able to get into as we have more information in the coming years. And so while we can't do that yet, I think that's the end goal and kind of the long-term goal of this work.
In this study, were you able to identify any measurable differences in economic burden for early onset compared to adult onset FSHD?
We have that information, but we haven't looked at that breakdown, but we could do that. Yep.
How does the economic burden of FSHD compare to um how I'm sorry, let me rephrase that. How does the economic burden of FSHD change depending on the location where the individual lives?
Ooh, that is another thing that we, in theory, do have that data a little bit across both the claims and the survey. We asked in the claims data, we have information about region, like South, what are the 4 regions in the US? East, South, West, I forget what the exact breakdown was, but we have information by region in that in the claims data. We also have an interesting breakdown of suburban versus rural, which is also interesting because we know rural communities can have more barriers to accessing care. And so that's another thing that we haven't done that breakdown at this point. And actually, I take it back. We wouldn't be able to do that right now, not without having starting another study. So we couldn't do that there. We could look at it with our survey data, but it's not something we've looked at yet. These are all such wonderful questions. I wish that we were able to answer them all, but not yet, but we could.
So, from what you've seen through the study, how does delayed diagnosis impact lifetime cost of care for FSHD, and what research is being done to improve early detection?
Hmm. Um, yeah, I could not speak to the delayed diagnosis question in our research right now. I don't think we would have a way to start to get at that in these particular studies. But the question of improving diagnostics for FSHD and getting to that earlier diagnostic is really interesting and important. And I know at the society we're looking at that from a number of perspectives. So certainly finding increasing awareness amongst the clinical community about FSHD so that can be recognized earlier by clinicians is one important thing I know Ashley here is working really hard on and that the society is thinking a lot about. Also, just, helping families understand what weighing the pros and cons of getting an official diagnosis, even though you might already know it's in your family, you might know what it is, but having that official diagnosis is important for some things like this type of research, and it will be important for being able to access care. And then the other aspect too is just some of the pains of genetic testing. It's an expensive process, it's complicated, it takes a long time, and so we're always looking at that technology and that the ability to improve that diagnostic process so it's more accessible to a broader group of folks and it's faster. So, I mean, over the long term, we know we need to improve this and get to earlier diagnosis and faster diagnosis. It's going to take a multi-pronged approach across many years and many organizations and stakeholders, even just beyond the society.
Thank you. What can patients and caregivers do to support research on the financial impact of FSHD, some of the topics that we discussed, for example, and how will this data help prepare for future treatment, access, and reimbursement discussions?
Yeah. One of the most obvious things is that ICD-10 code. Make sure that's on your record because then when researchers go to look at medical claims, at healthcare system expenses, regardless of what country you're in, that's how they're going to find FSHD cases in those databases. So that's hugely important, having that on your record. Um, I think staying plugged in with your advocacy organization, whether it's a society, whether it's one locally in your country, we are working through Project Mercury right now, which is a global initiative to tackle some of these issues. We're working collaboratively with countries all over to do more of these studies in more countries in the coming years. So we're hoping to secure funding to do that. So stay in touch with your local organizations because you might have the ability to take part in a survey like this in the future. Um, and when we do perform those studies, you'll be plugged in and you'll be able to participate. What was the second half of that question, Ashley?
Let me go ahead and find it.
Sorry.
So, no, it's okay. How will this data help prepare for future treatment access and reimbursement discussions?
Yeah, I mean, this is the conversations and decisions that have to be had for reimbursement are going to look across. I mean, it's a complicated process, right? But having economic data is one of the several inputs, and it's a very important one that will ground that decision-making process moving forward. So all we can do is generate it and do as best we can to get it out there and get that information to the payer systems, and use that to make our case for why we think we're going to argue for a favorable decision for covering future treatments to FSHD. So that's how it's going to impact, and that's how we're going to be using it.
Perfect. And it sounds like, or it sounds, it looks like that's the end of our Q&A. So thank you everyone so much for submitting your questions. They were great, and we really appreciate you engaging with this and being involved. Thank you, Amanda, for this presentation, and also to June for helping lead this and the information that you shared with all. It was really appreciated, and we look forward to seeing how this is used in the future.
Thank you, Ashley. Thank you, everyone, for listening.
Yes, thank you. Everyone, thank you again for joining us today. We truly appreciate your time. We also appreciate you making the commitment to be here, to learn all that you can to ensure that you are advancing research, that you are advancing our knowledge of what FSHD is and the impact that it has on the community. So thank you. We hope that you will consider joining us at our future FSHD University webinars. We have a few coming, including our annual drug development update in December. So please make sure you look at our calendar of events for that. And of course, as Amanda said, please stay involved, plug in with our different programs, look at some of our gathering place groups, our chapter meetings, etc. So with that, I wish you all a great day and thank you so much. Goodbye.